exam similar to the mouth and throat. However, there's a lot of different pieces of information that you can get. And you'd be surprised how many patients will come to your practice and they're going to end up looking up their nose, looking in their ear because you're concerned about some type of an infection or sinusitis. So let's first start with the nose, and like everything we've done so far up till this point, what's the first step of a physical exam? What do we always do initially? We do an inspection, exactly. So no different here. We're going to inspect her nose. Now, from the obvious things on the external skin surface, yes, you still want to look for any discolorations, abrasions, scarring, very similar to what we've been learning so far in our third semester class. But you also want to check to see if you see any discharge. Is there any blood? Is there any pus coming out of the nostrils? Do you see any deviation that could possibly indicate a new fracture or an old fracture? Obviously, if somebody fractured their nose initially, you would probably expect to see multiple contusions, it would be inflamed, but old fractures, you may actually see a deviation in the septum. That is possible. But discharge is the biggest thing. Obviously, see if there's any blood or any clear fluid. Without me going into it, what does anybody know if you see like a clear serous fluid? What could that indicate? And that also same for the ears.
A concussion.
What's that?
A concussion?
Well, what is the fluid?
CSF.
Potentially it's cerebrospinal fluid, which could indicate not so much, I mean, certainly a concussion, but more concerning is a closed head injury. So if you see any kind of clear fluid coming out of a nostril or an ear canal, definitely be very, very concerned for a possibility of a closed head injury. All right, so I'm gonna use my cheat notes here because I wanna make sure I don't miss anything for you folks. Okay, so that's pretty much it with regards to the nose infection. Next is gonna be palpation. And the palpation is really simple, all right? I like to kind of come, put both hands here on the temple. And again, this is just so I can brace it. The problem is if you use one hand, a lot of people will tend to kind of push the head that way. So I like to kind of come in with both, but it's preference. And really what you want to do is you just want to palpate to see if you see any tenderness. All right, come on either side, watch your eyes. That's it, was any of that tender?
Nope.
So really what I'm feeling for, again, I'm feeling to see if I feel any physical deformities, obviously really tenderness with this, and most importantly, make sure nothing's moving, right? If you see any, if you feel any crepitus or, yeah, so crepitus would be that kind of, you guys know what is crepitus? What is crepitus? Ever heard of it?
Like crunching?
Yeah, it's kind of crunching, it's this kind of crunchy noises, sounds like almost like Rice Krispies almost. Definitely, could indicate some type of cartilage pathology or whatnot. All right. A lot of you will have crepitus in this area and usually don't think anything of it. But if it's, if it's swollen and if it's tender, hey, you want to be concerned that somebody may have a septal fracture. So that's really it with, the palpation. There's not much more to palpate. Now, could you do a sniff test? Yeah, of course you could do a sniff test to see if there's any, occlusion, right? So really, to do that, I'd cover one nostril. Can you go ahead and take a sniff to your nose? Go ahead and do the same here. Okay? And basically you can see if both sides, if she can sniff, easily just on the same side. If there's a deviated septum, does anybody have a deviated septum that they know of? Yes, so do I. So I could do this side, no problem. This side, it definitely feels a lot more restricted, and I definitely know I'm not getting as much air as I do when the left side is open. Okay. So now we want to go in our internal examination. Now, some of you have an actual rhinoscope. Does anybody have a rhinoscope? I'll show you how to put it on real quick. One of you's had it. I think Mike, I think you had one. The little green top piece. Oh, here it is. So, yeah, Dr. Line and I, we were talking. These are better to use, but the problem is it's difficult to sterilize them. Really the proper way to sterilize these is in an autoclave, but they are better because you can visualize it. So your otoscopic head comes off and the rhinoscopic head, whoops, I'm sorry. On your otoscope, you'll actually take off this piece. This piece screws into the rhinoscope, like so. And you just clip it in like usual. And there we go. Now I'm not actually going to insert this into her nose, but like I said, these are the better way to do it. But she would tilt her head back. I'd apply a little bit of pressure here at the tip of the nose, and then this would go right in this way, and then I'd switch my hand placement. I'd actually come to the other side and do it for the other. So let me demo it with the actual specula because there's a couple things you want to take into consideration. Now, with using an ear specula, what's one of the things are you most concerned with? Going too far. Now, do you have any tricks for, or is it just kind of feel?
Just by feel,
Yeah.
just make sure you stay lateral, because if you go medial,
Exactly.
you can hit what's called Kesselbeck's plexus.
Kesselbeck's plexus, which I actually had cauterized a couple weeks ago because it was bad.
And it's very rich in vessels, and you can actually give them a nosebleed.
Yeah, and these usually don't clot very well, so patients will have repetitive nosebleeds, so you don't want to. So definitely want to stay lateral, and usually the rule of thumb is you never want to go past, and so if you can't see the tip anymore, then you can't go any further, right? So you really want to be sure you can visualize the tip of your ear specula at all times. So she's going to tilt her head back. All right, Rebecca, I'm just going to insert this into your nose. It's going to be a little uncomfortable. Just let me know if you have to sneeze or if it feels a little uncomfortable. Because what happens if they sneeze or they jerk their head? Oops, you don't want that. So she tilts her head back. I apply a little bit of pressure. And again, I'm trying to be as minimalistic in my contact as possible. Don't do this, really just a couple of fingertips just to help stabilize. And that's really all I'm trying to do. Okay, and if you want to zoom in here, come on over here, Annalise, you can see.
The easiest, my opinion on this one is get the tip of it in there, then look.
Yep,
Okay,
exactly.
don't try to like go in and
Exactly,
stick
and
it
you
up
can
there,
see
'cause then you lose track of it. Same thing with the
100%.
ear, by the way. Stick it in and then look.
So you can see what we do is we kind of put it in, and then I kind of move laterally to get some of the tissue out of the way, and now I can start my exam. Now, while you're here, a couple things you want to look for, okay? You're going to first be able to, again, see if you see any bleeding. Is there any new blood or dry blood, right? Dry blood's going to have that kind of darker, crusty, look to it. Obviously, a new arterial bleed is going to be rich, red, and whatnot. All right, so not only do I want to look for that, again, look for any kind of mucus, any possibility for CSF. That's one. Couple things you can also visualize. You all remember from your head and neck anatomy the concas, superior and middle nasal concha? So you should be able to visualize, those are also known as turbinates. So you should be able to visualize that. Okay, so you want to be able to tell us that you can, at least you're looking for it and see if you can visualize it. Now you want to look at the septum. You want to look at the septal wall. Do you see a perforation? What's a perforation? Does anybody know what does that mean? Perforation. A hole, all right? Is there a hole in the septum? The septum should be uniform throughout. All right, so if you see a hole, that's a problem. Does it look straight or does it look kind of crooked, aka deviated? You also want to look at the mucosal membranes. Look at the color. You had any, a virus? Have you been sneezing a lot or coughing?
Sneezed quite a bit this morning.
Okay.
I just ate wasabi.
Nice. Awesome. So the reason why you ask is because patients that are, repetitively blowing their nose or they have some kind of a viral rhinitis, you may actually see the septal wall, the mucosal membrane surrounding it. It's going to be red. It could be a little inflamed. Okay. If somebody's kind of having more of an allergic rhinitis or they're constantly using those nasal sprays, it could have this kind of blue-gray tint to it. All right. So have you ever looked on those recommendations? You're never really supposed to use those like Afrin nasal sprays more than like 2 or 3 days. Yeah, there's a reason for that. They're actually not good. There's a pretty nasty chemical in there that overuse can actually. One of the things it actually does is it can actually preclude you to nosebleeds. I learned the hard way. I was one of those bad patients that used it for like over 2 weeks straight, and I ended up with a nose cauterization. So
They're vasoconstrictors.
Exactly.
And vasoconstriction over too long a period of time can be problematic.
Big time.
Okay.
All right, so you also want to see if you see what's called a polyp, all right? Has anybody ever Googled a nasal polyp or ever actually had a nasal polyp? Basically what it'll look like is almost like an outpouching of skin, like a little ball, type formation. Usually not a big deal. If patients are symptomatic, an ENT would actually go in and remove those. All right, you have polyps everywhere. You can have polyps in the intestines. So if you see any kind of like I said, like a little ball, it looks like a piece of tissue. That's what we call a polyp. All right. If you see a polyp, always send them to get checked by an ENT because you want to make sure that it's nothing abnormal. And sometimes the ENTs will remove them. Sometimes they'll just leave them in place. All right. So let me just double check to make sure. I didn't miss anything, and then I'll show you a couple other things. Okay, perfect. So any questions with that? What's that?
I'm scratching.
Oh, I'm sorry. I'm like, now,
Sign language.
that's okay. Now, you actually don't need to change the speculum, okay? Because, you know, the nose shares, you know, they're both, they share the same pathway, meaning they all end up in the same place, all right? Nasopharynx. So you have one nasopharynx, two nares end up going into one nasopharynx. So it's okay to go from side to side without actually changing this. But again, you know, very similar to the ear, doing the right nostril, use the right hand. Left nostril, use the left hand, okay?
So would you recommend like holding it like you're holding it, or like bracing it like we did for the ear?
I mean, honestly, yeah, I mean, you can do this. Whatever you're gonna have most control with this.
Yeah.
Because, you know, with the ear, you have a little margin for error. Here you don't, because one little flub up, you can hit kiss and box plexus, and let me tell you, they bleed a lot. So whatever you feel like is most comfortable, you know, because remember, the two things that you're trying to accomplish, make sure her head is straight, make sure she's comfortable, and make sure the light source is always on. Okay, get it in there, like Doc said, and then go ahead and look. Okay. All right, any questions on the nose?